Hey guys, I've got chapter 64 I'm going to lecture on, and it's pretty short. I'm going to try to keep it short for you guys. So let's get started. I'll share my screen. This is hearing disorders as part of the sensory chapters. So again, briefly, I'm going to just cover a little bit of anatomy and physiology like I did with our visual. So you guys just remember your anatomy and physiology of the ear. So obviously we have our external ear. The external ear includes the auricle, which is the pinna, and the external auditory canal. And the external ear is separated from the middle ear by a disc-shaped structure called the tympanic membrane. So you guys remember all of that, right? And then we have the middle ear, and the middle ear is an air-filled cavity. It contains the tympanic membrane, which is about 1 centimeter in diameter, and it's really thin. And it's normally kind of a pearly gray translucent color, and I'll show you guys a picture of that in just a second. But the tympanic membrane protects the middle ear and conducts sound vibrations from the external ear to the ossicles. And then we guys have our 3 smallest bones, the ossicles, the malleus, the incus, and the stapes, or stabies, however you want to say that, assist in the transmission of sound. So, crash course in remembering our anatomy. And then we have our inner ear. And we have, how do I get that off the screen? That's weird. Sorry, can't see my notes. Okay. So we have the 3 semicircular canals, the posterior, superior, and lateral, and these contain sensory receptor organs that are arranged to detect rotational movement. So like when we move, and are stimulated by changes in the rate and direction of our movement. And then the organ of Corti, which is also referred to as our end organ for hearing, transforms mechanical energy into neural activity. So that's what sends the impulse to the brain so that we hear the sounds. And this separates sound frequencies as well. So basically that's just kind of a crash course. You guys should know that, but just kind of review over it so you have an understanding of some of the disease processes that we're going to talk about that you guys need to know. So what's the purpose of our ears for hearing, right? So hearing is conducted. We have 2 pathways, air and bone. So sound transmitted by air, conduction travels over the air fluid, external and middle ear through vibrations through the tympanic membrane and the ossicles. And then sound transmitted by bone conduction travels directly through the bone to the inner ear, bypassing the tympanic membrane and ossicles. Normally, air conduction is the more efficient pathway for us to be able to hear. And so hearing is purpose, and then balance. So the vestibular apparatus in the inner ear provides feedback regarding our movements and position, and kind of the way our body responds to that. So assessment wise, again, here's this picture of the tympanic membrane, and you can kind of see it's when we're talking about that gray kind of pearly color, but it's really thin piece of tissue right there. So when we're inspecting or doing an assessment on our ears on our patients, we just want to expect that in external ear, look for deformities, lesions. Do they have like discharge or like crust coming out from the external canal? With the otoscopic examination, we use that to visualize our tympanic membrane. And again, a healthy tympanic membrane should be that kind of pearly gray color. Testing auditory acuity, there's a bunch of different tests that you can do. One of them is a whisper test, and that's where you cover an ear and then you stand. We're testing the uncovered ear. You stand 1 or 2 feet away and whisper. And if the hearing is normal, they should be able to hear, what it is that you whispered. And of course, I'm sure you guys have seen the Weber test. That's the bone conduction. We like tap that tuning fork on a solid surface, and it creates those vibrations. And then you put it on the head, and that's the bone conduction that we're talking about. And this is useful for detecting unilateral hearing loss. So you can test it in both ears to see if there's hearing loss on one side and not the other. And the Rene test, that distinguishes conductive versus sensory neural hearing loss. And you guys should know that, but I'll review those 2 different types of hearing loss as well. And then some diagnostic tests we have are audiometry, and that tests frequency, pitch, and intensity of sound that you're able to hear. So I've been in several audiometry tests with my kids. If you guys have ever taken your kids to an ENT, it's usually kind of take you into a little padded room and test different pitches and frequencies that your kids can hear, or adults too. Table 64.2 describes the severity of hearing loss, like as associated with like different wave frequencies. So I don't expect you guys to know that, but it's just interesting for you guys to look at. Because obviously there are different depths of hearing and hearing loss. So hearing loss, different types of hearing loss that we have, it occurs more in men than in women. So women, if you think that men tend to not listen more, maybe they just can't hear. Maybe it's not a listening problem, it's a hearing problem. So we have sensorineural. This is caused by damage to the cochlea or the vestibular cochlear nerve. This can occur with aging, noise damage. So if you listen to really loud noise, me as a teenager, listen to my music really loud, I probably have a little bit of sensorineural hearing loss. Drug side effects, which we'll talk a little bit about more when we talk about ototoxic drugs here in a little bit. Tumors, blast explosions. So, you know, like if someone's been around a large explosion, this can cause sensorineural hearing loss. And then your conductive hearing loss usually results from an external problem of the middle ear, like serum impaction, otitis media, allergies, your ruptured tympanic membrane, or even a foreign object that's in there that could be obstructing the tympanic membrane. So risk factors for hearing loss is family history, and some of it is congenital, or they can even have congenital malformations of different parts of the inner ear. Use of ototoxic meds, which we're going to cover in a few minutes. Recurrent ear infections, and we'll see this a lot like in young children who have recurrent ear infections, and then they'll test their hearing and they've had some sensorineural hearing loss. Chronic exposure to loud noises, so people who work in like construction sites and things like that, they've had chronic exposure to those loud noises over a really long period of time, and that's caused their hearing loss. And then again, perforation of the tympanic membrane can cause hearing loss as well. So what are some manifestations? Tinnitus. So tinnitus is the perception of sound, often ringing in the ears, or like a buzzing, a ringing sound in the ears. So when we talk about tinnitus, that's kind of how people describe it. Chart 64.2, there's a little chart in there about hearing loss, and I would just kind of look over that chart. So early symptoms we might notice in people with hearing losses, and sometimes they're very good at like coping with it, or, you know, just getting along in their day-to-day, or they may not even realize in the beginning that they have hearing loss until it becomes super noticeable. But early symptoms is maybe we notice like speech changes in somebody who has hearing loss. Their words might sound more flat. They might be indifferent in a social situation, or they may even seem standoffish, but maybe it's just because they can't hear the conversation that's going on, and are just unable to participate, and it may come off as like indifference, or like them being introverted, but maybe they just can't hear. Suspiciousness, so, you know, or maybe they only hear like parts of a conversation, and it comes off as, you know, sounding like you know, maybe something bad, you know, or somebody's talking about them, or, you know, they may misinterpret a conversation or a situation because they can only hear bits and pieces of it and not the full conversation. So those are just some different, you know, like early manifestations you may see it with somebody as they progressively lose their hearing. So guides for communication with the hearing impaired. Review chart 64.5, that's communication with people who are hearing impaired. But some key things to remember are we want to use a low tone and a normal voice. So screaming at them is not always necessarily the best way to communicate. We want to speak slowly and distinctly, so make sure you enunciate your words. you're not, slurring and everything. If we can reduce background noise when we're trying to talk to these people who are vision impaired, so if there's music or TV in the background or you're in a large crowded place, that might not be the best place to try to communicate important things, or to have that conversation with somebody who's hearing impaired. So if you can ideally have it in a situation where we can kind of reduce that background noise so they can hear us better. And then you need to be face to face, so you need to be looking at them, because a lot of people rely on your visual cues to determine the context of the conversation, and also reading lips helps them pick up some of those words that they can't hear, because they've gotten used to our body language to interpret, and also reading lips to compensate for what they can't hear. And then use gestures and facial expressions. I always say, and you guys, I've been using my hands this whole time, but if you tied my hands behind my back, I wouldn't be able to have a conversation. So I'm really good at using gestures when I talk, but gestures, facial expressions, our body language helps convey the meaning behind what we're saying when maybe they can't necessarily pick up on tone. A lot of times people say it's not what you say, it's how you say it, but then someone with hearing loss can't hear how we say it. So we have to be able to use our gestures and our facial expressions to try to convey that meaning that we would normally maybe use with our body language or tone of voice. If necessary, we can also write out information, or obviously if somebody can't hear at all, sign language translators for our patients. So conditions of the external ear. So serum impaction. I always think of Shrek. It's, I know it's like starting to get old now because that movie is come out in like early 2000s, but he puts that Q-tip in his ear and pulls out a whole glob of wax and then lights a candle to eat dinner with. It's like his earwax candle. But anyways, we can get impaction of that wax within the ear. And then that can cause hearing loss and, just discomfort or feeling of fullness even. So this can be removed with irrigation, suction, or instrumentation. So when we irrigate, we want it to be warm water, and we want to use gentle flow. If you use too forceful of a flow of water, what can happen? We have that tiny, thin little membrane, the tympanic membrane, we can rupture it, and then fluid can get in the inner ear, and then infection and lots of problems. So we want to be really careful that it's just a very gentle flow that we can use to get that wax out. And then they can do direct visualization. So use a lighted scope with a tool to dig that wax out. And I know I tell you guys I watch TikTok, so those are some of my favorite TikToks videos to watch, is because you can buy anything on Amazon now, but you can buy those little scopes, which is probably not good for people because they're probably damaging their tympanic membrane, or risk for infection when they're doing that kind of stuff at home. But there's just something it's so satisfying about watching people get all that wax out of their ears, and it's kind of cringy at the same time, but you're like, oh my gosh, look at all that. It's okay, I'm weird. I like to watch those videos. But yeah, so we can use those tools and go in, and usually, it should be a trained professional that's, helping you with that. But and then we can use warm glycerin, mineral oil, or half strength peroxide to soften that wax before we try to irrigate it as well. So you can instill that and then wait, and then try to irrigate the wax if it's really hard and hard to get out. We just don't want to, if it's hard to get out, we just don't want to continue to force our irrigation, because then we can rupture that tympanic membrane. Foreign bodies, this we see a lot with kids. They stick stuff in their ears, in their nose, everywhere. I got a call I want to say it's probably a year and a half ago, that my oldest son, I'm like, why is this my 7-year-old that's doing this? But his teacher called one day in a panic because she's like, he stuck a bean in his ear. And I'm like, what were you doing? So I had to take him to the doctor, and she had the little curette. And anyway, she was able to get it right out. But I was like, why'd you stick it? Why? He's like, I don't know. So, kids they stick stuff in places just to see if it'll fit. I don't know. But we see that a lot with kids. We can remove it with irrigation, suction, and instrumentation, just like we do the wax. Objects that can swell. So if they're exposed to water and they would get bigger, then we wouldn't want to use irrigation. So vegetables like the bean that was in my kid's ear, insects. So if you got like a fly or something in their ear, or like something flew in their ear, we wouldn't want to use that because that'll make the bugs swell and then it's harder to get out and then it's just cause more problems. So in those situations, we can use mineral oil, and usually the mineral oil will help move that object close enough to the surface that we can get it with instrumentation. Foreign body removal can be dangerous and may require extraction in the OR if, it's packed down in there, because again, you risk the damage and rupture to the tympanic membrane, and then, things can get in the middle ear and cause infection. So we would try to remove these things in the office outpatient if we can. That would be kind of like an extreme situation. I was very glad that she was able to just pop that little bean right out of his ear quickly. And then I'm like, oh my gosh, what am I gonna do with you kids? And then we have external otitis. So a lot of people know this is like swimmer's ear. Obviously, it's just inflammation of the external ear, and it could be caused by staph and pseudomonas or fungal infections. And a lot of times it's because we get water, exposure of water, and there's, different bacteria and pathogens in water. And this can cause pain and tenderness, discharge. We might start seeing, some nasty discharge coming out. Edema, redness, pruritus, so itching, feeling of fullness in the ear. They may have temporary hearing loss if, they have a lot of feeling of fullness, like water in the ear. People who swim a lot, they call it swimmer's ear, water in the ear canal. If your kids are like little fishes in the summer, like mine, they occasionally, will complain of earaches, like after we've been swimming all day. So when somebody has this, you want to instruct them not to clear the external auditory canal with cotton tipped applicators, because it's already red, it's already inflamed, and this can cause more damage and more risk of pushing that infection further into the middle ear. We want them to cover their ear when they shower, so they can take a like a cotton ball or lamb's wool and coat it in petroleum jelly and just stick it in that, not down in the ear, but just right on the outside. And you could even, just press it down to where it feels gently, to where it just feels that external auditory, so that they can wash their hair or whatever, but they don't want to swim or be like submerged in water while that's healing for 7 to 10 days. Antibiotics, otic drops, or systemic antibiotics if it's severe and they're running fever and stuff. Prevention: plug their ears when they're swimming. After they come in from swimming, they can put alcohol drops on a cotton pad, or they sell those over the counter, like swim ear drops over the counter, and that basically just kind of dries out that extra moisture that's within the external ear canal. So that's some prevention that we can do there. Other conditions, or conditions of the middle ear, sorry. So we have, like we said, we can have perforation of the tympanic membrane. This is caused usually either by trauma or infection. So we get that infection in there, and it can build up pressure from fluid and just inflammation, and it can rupture that thin little membrane. So infection is the most common cause. Also foreign objects, like I said, we get those foreign objects down in there and it can puncture that. So don't be like sticking like bobby pins or paper clips in your ear to scratch them. I used to work with this girl, and I would always walk by and she'd have like a paper clip in her ear. I'm like, what are you doing? You're gonna freaking rupture your tympanic membrane. Stop it. I was like, I can't. I was like, please don't do that. You're making me cringe. A lot of times this just heals spontaneously, and we want to protect from water from getting down in it, because obviously if this is, like we said, this is a barrier between the external ear and the inner ear, and so we don't want things to get down in there, because then we can cause further infection. So we just want to protect water and things from getting down in there while it's healing. We see this frequently in children. The pathogens that cause infection are usually bacterial or viral. Sorry, I moved on to otitis media. We see this, obviously, ear infections in kids. We know that's pretty common, right? Manifestations include ear pain, fever, hearing loss. Like, I had so many ear infections when I was a little girl. And I just remember waking up in the middle of the night just crying because my ears hurt so bad. It's no joke. Like, it's very uncomfortable for kids. It can get really, really painful. I just remember a lot of sleepless nights with ear pain, probably because my parents just didn't take me to an ENT. Because, walk it off, you'll be okay. Table 63.4 is clinical features of otitis, and that compares external otitis and media, which is otitis of the middle ear. And so it just kind of compares those side by side. So that's a good little table to look at. Treatment for this is obviously antibiotic therapy. So we can do oral or the drops, and sometimes a combination of both, depending on the severity of the illness. And then the ventilation tube. So you will see kids with recurrent otitis media that will need the ventilating tubes, and this allows equalizing of pressure, and they can stay in place from 6 to 18 months, and they usually will fall out spontaneously on their own. And here's just a picture of what those tubes look like. Let's see, the serous otitis media is that the fluid in the middle ear without evidence of infection. So maybe they just have a feeling of fullness and like fluid in the ear, but there's no sign of infection. And then chronic otitis media is the result of recurrent episodes of the acute otitis media. And this can damage the tympanic membrane, the ossicles, and can even involve the mastoid bone. Treatment would just be to prevent the acute otitis, but then there's some surgical interventions as well. So the tympanoplasty is surgical reconstruction of the tympanic membrane. The purpose of the tympanoplasty is to reestablish a middle ear function close to the perforation to prevent recurrent infection and improve healing. And the ossiculoplasty is reconstruction of the bones in the middle ear. And then the mastoidectomy is removal of the diseased bone, mastoid ear cells, and cholesteatoma, which is tumor, to create a non-infected healthy ear. So those are just some different surgical interventions. I don't expect you guys to memorize those all, but just know, there's different interventions we can use to treat those if they get super serious. So, hold on just a second. Okay. Sorry. All right, so health history. We need to include data about like their previous ear disorders, problems, hearing loss, vertigo, anything like that they've had, and just ask how long they've had it, intensity, describe it to me, what are the causes, have you had previous treatments for it, any surgical interventions or anything like that. Of course, we need to know what medications they're taking, again, because some of them can be ototoxic, and we're going to talk about that in just a minute. And you want to, like we said, just do your assessment. Do they have any erythema, edema, lesions, discharge? If they had discharge, just note the color and odor, if it has any odor. And then if they've had any previous hearing tests, we would want to see if we can get copies of that to review. Like, do they have documented sensory neural or conductive hearing loss in the past by an audiologist? So that's just kind of reviewing that process before they have this mastoid surgery. And there's a whole section of this in your book. That's why I'm reviewing it, because I think it's good to know. But the major goals are on page 1930 for you guys to go and look. So the nursing process for a patient undergoing the mastoid surgery, obviously reduce pain and anxiety. Pain relief, they a lot of times are going to have sharp shooting pain. And this is normal as the eustachian tube opens and allows air to enter into the middle ear. Sometimes they'll feel that sharp shooting pain. I'm sure you guys have experienced some kind of ear pain at some point, and it just kind of catches you off guard. And that's normal. But if the patient has constant throbbing pain, this can be indicative of an infection. So we would want to monitor for that, educate the patient about that. And then obviously risk for infection is going to be high. So infection prevention, packing, they can even pack it with stuff that's been soaked in an antibiotic solution. And they're usually given prophylactic antibiotics, so they'll need to take the full course of that. And they want to keep water out of the ear for at least 6 weeks. So we've got to teach them that they, obviously can't do water activities and sports and things like that. But even when they shower, they need to be really careful. They need to put that cotton ball that's covered in the petroleum jelly and put it in their external canal so that it protects water from getting there. My kids, when they had tubes, I was really nervous about getting water in their ears. I always told us, like, both of my boys have recurrent ear infections and both had tubes. I think one at 18 months and one at, I want to say like he was right at a year old. Anyways, I got custom earplugs made for them, which probably wouldn't go that far, but it is a possibility because it was super easy for them to make. They just take a little mold of their external canal and then they can put those earplugs in when they shower. And if they have chronic ear problems, it'd probably be a good investment if they could afford it. But that's just another option. But a really easy, cheap way that we can educate our patients is that cotton ball with petroleum jelly when they shower. They may have some serosanguinous drainage from the external canal, and that's normal in the postoperative, the first few days postoperatively. Improved hearing, so they're going to have some impaired verbal communication in the immediate period after. It's going to be hard to hear because they have edema and accumulation of fluid after the surgery. So this will improve. It's going to take a few weeks for that, edema to go down, the fluid to go down. So we need to, again, do those things that we can help to improve communication. So like we said, face the patient and make eye contact to reduce that environmental noise. And then we want them to have the absence of injury. So anytime we're dealing with stuff in the ear, we have vertigo and balance problems, we're at risk for injury from falls, right? So antiemetics, and I love this word, I'm going to try to say it right, anti-vertiginous medications, which is anti-vertigo medications like antihistamines, can help with those balance issues. And then we want to assist with ambulation to prevent falls. And they want to avoid heavy lifting, straining, exertion, things like that. Anything that's going to increase the pressure in their head, including nose blowing. So like blowing their nose really hard, lifting things that are heavy, straining, physical exertion, that's going to create pressure in our inner ears. They need to avoid that for 2 to 3 weeks after surgery. And this prevents dislodging of the tympanic membrane graft, or if they have like the ossicle prosthesis that's put in, we don't want that to be dislodged because we don't want increased pressure in our ears. So we just want to teach them to avoid those things. Okay, so conditions of the inner ear. Dizziness is a really broad term. What does it mean? It's any altered sense of orientation to your space. So, you feel dizzy. What is vertigo? So dizziness and vertigo are not the same. Vertigo is an illusion of motion or a spinning sensation, obviously when you're not moving, you're spinning. And then nystagmus is an involuntary rhythmic movement in the eyes, and this is associated with our vestibular dysfunction. So when our inner ear is off, you can see the eyes go back and forth like this. It's really cool if you've ever seen anybody with nystagmus. So disorders of the vestibular system affect more than 30 million people in the US, and falls resulting from these result in over 100,000 hip fractures a year. So a lot of people suffer with this stuff and don't ever, seek treatment, or their treatment's ineffective. And then, they end up getting injured because their inner ear is messed up. So again, we talked about what are some signs that they may experience. Tinnitus, that's that, tinnitus is always a sign of an underlying disorder, but it's that roaring, buzzing, or hissing in one or both ears. Labyrinthitis is just exactly what it says. It's inflammation of the labyrinth. And this can cause incapacitating vertigo and nausea, vomiting. Benign positional vertigo. There's a lot of people that suffer from this. Probably a lot of patients that you have that come in and have falls are going to have this underlying problem. So that benign positional vertigo. And what it is it kind of comes and goes. It's a brief period of incapacitating vertigo. So, all of a sudden everything just starts spinning. And that occurs when we have a position or a change in position of our head in respect to gravity. So the thought process behind this is that we have small crystals of calcium carbonate form in the inner ear. And we can have this benign positional vertigo be stimulated by either a head trauma or an infection. But basically what they're saying is the little calcium crystals that we have get displaced. And then when they move around, when we have like a sharp position change, then it causes that vertigo for those patients because the crystals are kind of floating in and out. And it causes that vertigo and that dizziness. So I actually, I've not been officially diagnosed with this, but I was having some vertigo when I lay in bed. Like I would be sitting up and then would lay down in bed. And as soon as I lay down in bed, like the room was spinning, like, and I felt like I was going to throw up. And I didn't understand what was going on. I mean, this was just a couple of years ago. And it was for a period of time only when I was laying in bed. And then there'd be some times where I would be like at work and I'd be walking down the hall and I would, someone would call my name, like when I was working on the unit, and someone would call my name and I would turn around real quick and I would turn my head to the left if I did it really like a quick movement, and then everything would start spinning. And I'm like, oh my God, this is something's not right here. Something's wrong. And then when I knew it was a problem because I was driving and I turned my head to look, to see if a car was coming, and then everything started spinning and I had to pull over and call my husband to come get me because I didn't feel like it was safe to drive. So anyways, I was trying to figure out what's going on, talking to, it's a good thing about being a nurse. Sometimes you can just like, ping pong symptoms off of people just to, use your resources. But Miss Ward's ex-husband is a physical therapist at the hospital. And I was just talking to him about it one day and he's like, you probably have benign positional vertigo. He's like, you can do the Epley maneuver. And I'm like, oh, what's that? I was like, I've never heard of it. And he's like, oh yeah, it's super cool. So we just went in an empty patient room and he showed me how to do it. And what you do is you sit, so you have the patient sit up straight and then you turn their head 45 degrees to the affected side. So he's like, where are you having your dizziness? And I said, the left. So turn your head to the affected side and then quickly lay them back down in the supine position. And he had me probably even further than supine, kind of had my head like tilted back and left it there. And basically what you're trying to do is float those crystals back into place, those calcium carbonate crystals, because this is dislodgement of those that are causing the random vertigo when you turn your head. And when the patient really has this, you'll see the nystagmus in their eyes because we've got that inner ear thing going on. So he said, yeah, as soon as I put your head down, your eyes were like, like nystagmus for sure. So, and they can kind of get dislodged again. So I blame my husband because I said we were having a pillow fight. Like it got better, like, didn't have any problems for like 6 months to a year. And I was having a pillow fight with my family and my kids, and somebody smacked me. I'm so delicate. I'm so delicate flower. I can't get hit in the head with a pillow. But I got hit in the head with a pillow really hard, and then I started having the dizziness again. And I'm like, y'all knocked my crystals loose. So then I, now that I knew how to do the Epley maneuver, I could kind of do it from home. And there's some YouTube videos that you guys can watch too, and it shows you you can do it independently by yourself. But you can teach your patients how to do this because, there are times where it can come and go just depending on what's going on. But this can help that Epley maneuver. And I'll post a video so that you guys can watch how. But anyways, that's my story. So at least you guys know about it. Because I was like, when he told me about it, I was like, you're making that up. Like, I've never heard of that before. And he's like, no, it's a real thing. Like, learned about it in school. And I'm like, well, okay. I guess I must have been sleeping during that part. I don't miss it. So I don't remember that. And then we have ototoxicity, or several medications can cause adverse effects on the cochlea, the vestibular apparatus, or the cranial nerve. So I want you guys to review chart 6410. Most of these meds cause irreversible hearing loss. Aspirin and quinine, when stopped, this hearing will normally be restored, but typically the other medications are going to cause irreversible hearing loss. So I just want you guys to review those medications and be familiar. And then when we start those people on those meds, they need to be alerted that that can happen and that they can have that hearing loss. Even, you know, months after they've taken that med, they can still have hearing loss. So read over that chart and just be familiar with it. It's a pretty short list of meds, but I just want you guys to be familiar with it. And then the last thing we're going to talk about here, just kidding, is Meniere's disease. Oh, shoot. So Meniere's disease, and here's this little graphic for you. But basically, just a quick anatomy review. We have a fluid in our inner ears called endolymph, and it's a potassium type fluid. And this fluid is normal and it's supposed to be there, but it helps us hear and it helps with our balance. And Meniere's, people who suffer from Meniere's have overproduction of this fluid. And there's lots of different things that can contribute or can cause to this, and you can read about that in your book. We can have malabsorption of the endolymphatic fluid. There's like a little sac, it's called the endolymphatic sac, and it doesn't drain like it should. So it becomes full of fluid and can press or put pressure on hearing areas. And so that can create like a feeling of fullness in the ear, and also sensory neural hearing loss. But the main symptom that our patients are going to suffer with Meniere's is severe vertigo and nausea and vomiting, and then tinnitus. So that ringing or buzzing sound in the ears, and it's usually in one ear. Treatment. So what is our treatment? Like nursing intervention wise, we can educate our patient on a low sodium diet. This helps assist in the regulation of that endolymphatic fluid in the inner ear. We don't want to restrict patients' fluid intake unless, you know, they have another reason to. I mean, hydration is important, but we can teach them that they want to spread their hydration out over the day. So like, don't chug like a huge big jug of water all at once. Like, you can have a normal amount of water, but just kind of space it out throughout the day so you're not just intaking a huge amount of water at once, because that can increase the endolymphatic fluid. So low sodium diet, and just kind of pace their water intake. And then they need to avoid caffeine because of the diuretic effect. They need to limit food high in sugar. So we need low salt and avoid really high sugary foods and caffeine for these people. And this is going to help with that, all with that fluid balance in the inner ear. And then medication wise, we can treat with meclizine, antiemetics, diuretics. Surgical management can be used to eliminate attacks of vertigo. They can go in and decompress that endolymphatic sac in the middle and inner ear, you know, can be restored. So Meniere's disease, I assigned 2 practice and learns in the book, and I'll post this to Moodle as well so everybody knows before Monday. I think I assigned them to do March 8th. They're pretty quick, but one's on Meniere's and one's on glaucoma. So those are probably the 2 big disease processes that you guys need to be familiar with, that you're likely will see like questions on the NCLEX about. So that's why I assigned those 2 to you, so you know your different types of glaucoma and then Meniere's disease, and kind of what are the important things you need to know with that. Of course, what I've covered in the slideshows, and then we're going to do some fun activities in class on Monday. So be prepared to come and be interactive and learn, because we're going to do some fun stuff. That's all I have for you guys. So I'm going to get out of here and go home and spend some time with my family. But I will see you guys on Monday. Thanks. Bye.